Hello, I'm Dr. Ken Landau. Thanks for joining us. This is Well Now Doctor. We're going to be discussing vitamin D. In part one, we already discussed that it seems there's a major disconnect. There's a disconnect between all of the people who supposedly have vitamin D deficiency and the relative lack of disease caused by this vitamin D deficiency. Maybe what we really need to do is make a new definition. We said that there isn't any international standard, but according to most of the so-called experts in the field, the overwhelming majority of us suffer from low levels of vitamin D. So somewhere in the order of 25 to 100% of Americans are vitamin D deficient according to our current tests. Well, I suggest to you that our current tests are awful and we ought to completely disregard them. Supposedly, according to our knowledge of vitamin D is very important for the bones. If you have too low a level of vitamin D, you're going to fracture your bones. You're going to suffer from a variety of bone diseases, rickets and osteomalacia and osteoporosis. But we know that we're not in the midst of an epidemic of rickets, as a matter of fact. The overwhelming majority of doctors have never ever seen a case of rickets. Very common back 90, 100 years ago, not now, at least not in the developed areas of the world. And as a matter of fact, if we look at those people who are really deficient in vitamin D, according to the current experts, well, it's African Americans and Hispanics. And we look at those people and we say, now, geez, are these individuals suffering from an increased incidence of bone fracture? Or is it the Caucasian population that has a higher level of vitamin D? And as a matter of fact, it's the Caucasian population with a higher level of vitamin D where we see most of the fractures. And the people who have very low levels of vitamin D aren't the ones who are suffering from the fractures. So again, our definition needs to be thought through a little more carefully before we have all of these people taking vitamin D supplements that for the overwhelming majority of people are not going to make any difference. Not going to make any difference because to a large degree, the level of vitamin D in your system is going to be genetically determined. It's like if you want to have brown eyes and you happen to have blue eyes, ain't going to happen. If you want to become 7 feet tall and you're only 5'4", ain't going to happen. And by the same token, when you take all that vitamin D in because somebody has told you that you're vitamin D deficient, guess what? One, you probably weren't vitamin D deficient in the first place, and two, it's not going to significantly change, as we've discussed. Even when we pour the vitamin D into people, we still have low levels of vitamin D. Even those women who are pregnant, who are consuming milk and who are consuming fish and taking the prenatal vitamins, those women overwhelmingly are vitamin D deficient according to the current tests. Well, let's look a little bit about how we get vitamin D in the system. One of the ways is that we go out in the sun. After all, it's called sunshine vitamin. The sunshine vitamin suggests that if we go out at the appropriate time, we're going to get our vitamin D. But what happens as we get older? Because after all, it's the older population where we worry about the fractures mostly. It's not the kids who are 5, 10, or 15 years of age who are going to get the fractures. It's the people who are 60 or 70 who are going to get the fractures. And we know that the skin, as we grow older, is going to become what we call atrophic. It's going to get thinner. As it gets thinner, there's not enough chemical that's going to be impacted by the ultraviolet light to get to be the form of vitamin D that we can measure. So as a result, we know that if we look at people who are, say, teenagers, and we put the teenagers out in the sun for the same amount of time as we put a senior, an individual over age 65, out in the sun, the senior is going to make only about half as much vitamin D as the younger individual. So one of the situations that we have to face is that as you get older, as you get more at risk, theoretically, the idea that we should just go sit out in the sun, it's not going to work. Just can't work because you don't have enough of the tissue to manufacture the vitamin D. Now, we also know that there's a major confusion that's occurred in the ability of the skin to manufacture the vitamin D. So if we look at the people who are otherwise youthful, and we say, go out in the sun, you're going to make vitamin D, we have to be a little more careful than just saying go in the sun. Because we know that it's only the UVB rays, there are all sorts of different rays in the sun. And it's only the UVB rays, those rays that are defined as between 290 and 315 nanometers in length. And those rays are only going to come through the atmosphere basically in the summertime. So if you go out and it's not the summertime, you're not going to get any vitamin D. It's not going to be manufactured. You need those particular wavelengths, and those particular wavelengths only come through sometime in the summertime. And as a matter of fact, we know that if you happen to be Caucasian and you go out in the sun, you're going to make more of the vitamin D, or the vitamin D substance, than let's say if you happen to be African American. And we also know it all depends where you happen to be in the United States. So we know the closer you are to the equator, the more vitamin D you're going to manufacture, because there's going to be more of the ultraviolet light, this UVB ray, that's going to come through. So if we look at people who are up in Chicago or Minnesota or Seattle, they're too far north. They're about 40 degrees latitude. It seems that if we're talking about manufacturing the vitamin D in the skin, we have to be basically no greater than about 35 degrees latitude, say a line between Philadelphia and San Francisco. If we're south of that, then we're going to be able to manufacture it a little bit better than if we are north of that particular line. We also know that the vitamin D is only going to be manufactured between about March and September. So if you go out at some point between September and March, even if you happen to be in those areas where we said that you were most likely to get the sun, it isn't the kind of sun that's going to manufacture the vitamin D. So that's very important. And the vitamin D that's going to be manufactured, when it is manufactured, is going to go right to the fat cells and is going to be stored, hopefully. So some people have done studies and they said that, look, if we look at those people who make a lot of vitamin D because they happen to be closer to the equator, those people are going to live about 10 years longer. Well, again, I think we have to say that those studies are absolute hogwash. And we also know that some studies say that if you go outside and if you spend a significant amount of time in the sun, you're going to manufacture enough vitamin D to keep you otherwise normal. And again, we can say that probably isn't true. We also can say that to some degree, the amount of vitamin D that you need is based on the amount of calcium in your diet. So for instance, we know that your body can only absorb a certain amount of calcium. If you are consuming a massive amount of calcium, well, a lot of it's going to be getting through. So even if we only absorb 15 or 20% of a whole lot, that's going to be a lot of calcium that gets into the system. If you're only consuming a little bit, well, your system is going to, interestingly, make up for that. We know that there's significant genetic variation. So when we talk about people, we talk about people being basically alike. Their metabolism is alike, but that's exactly incorrect. We know that there are a lot of what we call polymorphisms, where there are certain kind of chemical abnormalities, or chemical variations. They're not really abnormalities, they're just variations in your normal genes, in the constituents of your normal genes, that have a lot to do with what happens in your body. So why do some people develop heart disease at a relatively early age? Why do some people seem to have high cholesterol? Other people have normal cholesterol. Why do some people seem to need a lot of sleep? Other people don't need a lot of sleep. It all has to do with the genetic polymorphism in a variety of different areas, and we know that that's very important as far as vitamin D metabolism, and as a matter of fact, it's thought that the genetic polymorphisms, or your genes, your genetic makeup, may well determine somewhere between 40 and 80% of your vitamin D circulation, your vitamin D metabolism. So we said that the sun hitting the surface of your skin can manufacture what we call pre-vitamin D, pre-D3. That's rapidly converted into D3 that goes to the liver, and then it gets converted, and that's what we measure. Well, interestingly enough, there's that enzyme in your skin that takes a chemical that's the forerunner of vitamin D, and it's known as 7-dehydrocholesterol. That's right, can manufacture cholesterol. And we have to be able to metabolize the 7-DHC in the skin. But guess what? There's significant variation in that particular enzyme. So let's say you have a particular variety of the enzyme that's going to be too low to be effective. Or maybe it's going to take the 7-DHC in the skin and shunt it off in the cholesterol pathway. Well, guess what? You're not going to be able to manufacture the vitamin D when you go in the sun. And then once you have this pre-vitamin D that's altered into vitamin D that has to go to the kidney to become at least activated, well, we know that the kidney has an enzyme. And that kidney enzyme that takes the vitamin D3, or D2 if you happen to take a supplement, it takes that vitamin D and it makes the 25-hydroxy vitamin D that's required by the kidney to manufacture the active form of vitamin D. Well, just like we talked about, the enzyme in the skin can be different depending on your inheritance, depending on the variation in your particular family. That's why osteoporosis runs in family. Diseases seem to run in family because we have certain kind of polymorphisms. And as a matter of fact, not only is it the enzyme in the skin, not only is it the enzyme in the liver, but it's also the enzyme in the kidney that can have multiple genetic variations that determine the level of vitamin D that's going to be in your system. And let's get a little more complicated. When the vitamin D is floating around in your system, it's not floating around free in your bloodstream. It's bound to something, and it's bound to another chemical that we call the vitamin D binding protein. And guess what? Just like the enzyme that makes the vitamin D in the skin, just like the enzyme that semi-activates the vitamin D in your liver, just like the enzyme that manufactures the active form of vitamin D that happens to be in your kidney, well, now we know that there's significant genetic variation in the vitamin D binding protein that shuttles the vitamin D from one site to another. And as a matter of fact, we know that somewhere between 85 to 95% of all the vitamin D in your system is bound to this vitamin D binding protein, about 10 to 15% loosely bound to a protein in the system we call albumin, and probably somewhere around 1% is actually free. And it's only the free form that can be metabolized, that can be activated. Well, we know that there's significant racial variations in the genes and in your genetic inheritance, and in the genes that you have that are going to be able to metabolize the vitamin D. So we know that race explains probably at least 25% of the variation in your vitamin D level. And as a matter of fact, we also know that genetic variation, the genes actually are going to be significantly associated, maybe to a degree of as high as 80%, what's going to happen with your vitamin D in your body. And as a matter of fact, if we look at some of these genes, just the vitamin D binding protein, we find that if we look at the African American population, as we've said and talked at length about in part 1 of the series, we said that the vitamin D level in African Americans is lower than it is in Caucasians. Okay. So we have a lower level of 25-hydroxy vitamin D. That's the kind that's measured in the laboratory. But we also have a lower level of vitamin D binding protein. Oh, that's interesting. So we have a lower level of the carrier substance. Well, we already have said that we don't really care what the vitamin D level is that you get from the laboratory because that's not active. We care about what the active form of vitamin D is. The kind of vitamin D that's going to interact with the parathyroid hormone, the kind of the vitamin D that's going to interact with your bone to either break down your bone or put the calcium in your bone. We care about the kind of vitamin D that's responsible for getting the calcium out of the intestine and into the bone, into the bloodstream. And as a matter of fact, we find that the African American population has a higher level of the parathyroid hormone, a higher level of the calcium in the system, and as a matter of fact, has a higher bone mineral density. Isn't that what the story is all about? Your bone mineral density. That's why you need some of the vitamin D, so you can make bones that are thicker. Well, it shows with studies like this that we've got to be a little careful on what we're talking about, because the rhetoric, the whole idea about this vitamin D deficiency being so widespread in the community, well, it probably isn't indeed the case. Let's talk about obesity. We know that we have a problem here in the United States. We say that approximately 1/3 of the population is obese. Body mass index, by definition, more than 30. We know that somewhere around 30%, a third of the population, is overweight. Body mass index between 25 and 30. So what's that have to do with the story of vitamin D? Well, vitamin D is a fat-soluble vitamin. Vitamin D sits wherever there's fat. If there's fat in your belly, that's where the vitamin D is going. So if we look at fat people and we compare them to thin people, and we draw some of the blood to find out how much vitamin D is circulating around in the system, guess what? The vitamin D in fat people is in the fat. The vitamin D in the thin people is in the blood. So we measure it when we test the blood of thin people, and we say that thin people have higher levels of vitamin D than fat people. But that's not indeed the case. But because the level of vitamin D in fat people is lower, we say they need supplements. They got to go and take some vitamin D because, after all, they have low levels of vitamin D. But they don't. We know that if you are fat and if you lose weight, that some of that vitamin D is going to dissolve back into the bloodstream. Well, that's very good, of course. We would like it to be in the bloodstream. On the other hand, if you're fat and if you say, hey, I don't want to be fat anymore, I want to go and get one of those surgical procedures, a surgical procedure, not the band, but surgery where they short circuit the way the food goes, so the food sort of misses some of the upper intestine. Well, guess what? If you don't have the ability to absorb the vitamin D in the duodenum, first part of the small intestine, or in the jejunum, the second part of the small intestine, if we're short-circuiting some of that because we want you to lose weight, guess what? You're going to have a lower level of vitamin D. Well, it's thought that if you're overweight, you ought to have at least 2 to 5 times more supplement than a person who is otherwise thin. And it's thought, geez, if you're really fat, if you're, we call it euphemistically, if you're obese, then, well, probably you're not going to spend as much time in the sun, you're not going to get as much physical activity. And we know the sun and physical activity are associated with higher levels of vitamin D. So another reason why you may have a deficiency in your vitamin D. So something to consider. And let's talk about babies. Well, we know that women need to pass on some of the vitamin D to their children. And now there's a major push to get women to breastfeed because obviously breastfeeding is very healthy for babies, at least in third world countries, less so here in the United States. But when we look at breast milk hardly contains any vitamin D. Breast milk contains somewhere less than 20 units per quart. And if we look at how much babies are going to consume, if we're talking about a baby might need 400 units, well, not going to get it from breast milk. And if the woman happens to be deficient in vitamin D, well, there's going to be even less, maybe only 2 or 3 units per quart of milk. So if a woman's lactating, she might have to go and take more vitamin D. And as a matter of fact, when we're talking about vitamin D, you can have a low level of vitamin D because you're not taking it in, or because, let's say, you're an individual and you have a milk allergy, or you have lactose intolerance, or because now you follow one of these cockamamie diets, or you're a vegetarian, or you're a vegan, well, all of those are going to reduce the amount of vitamin D that gets into your system. And if you happen to be breastfeeding for a long period of time and you're not getting any supplement, then you're going to be deficient. And if we look over the period of the past 20 years, in developed areas of the world, we're getting less sun. We spend less time outside. We spend more time inside. We spend more time in front of the computer, in front of the smartphone, in front of the iPad. So we're not getting the sun. And when we do get the sun, we're putting some sunscreen on that may do something. We know that our body weight is getting greater. We know we're doing less physical activity and we're consuming less milk. So the question is, how do you get the vitamin D in the system if you want to consume the vitamin D by diet? Well, one of the ways you can do it is you can have some fresh fish. And we know fatty fish, very important. So if we look at fatty fish, there's none better than salmon. And if it's fresh salmon, it's going to contain somewhere between about 600 and 1,000 units per 3.5 ounce serving. Now, when you go to the store and you get some salmon, chances are you're going to have 6 ounces, 8 ounces, or even more. So you can see that you can get a significant amount of vitamin D from fresh salmon. On the other hand, if it's farmed salmon, it's going to have considerably less. It's going to have only between maybe about 100 and 200 units because the salmon isn't getting the ultraviolet light. And we know if you get canned salmon has 300, 400, 500 units of vitamin D, all in every 3.5 ounce serving. Now, on the other hand, you could get some cod liver oil if you want. And cod liver oil, just a teaspoon of that would have anywhere between about 400 and 1,000 units of vitamin D. And if you have an egg yolk, supposedly that has a lot of vitamin D, but it doesn't. It only has about 20 units per egg white. Now, we have fortified foods, and a lot of foods are fortified, and the story will tell you after a bit. But if we look at fortified foods, the one that's most fortified in the United States happens to be milk, liquid milk. So if you look at liquid milk, per 8 ounce glass, you get about 100 units. And you get about the same thing nowadays with most of the other voluntarily fortified foods. So when you talk about yogurt, if you have 8 ounces, then you get about 100 units. If you talk about orange juice, it's about the same thing. If you talk about butter, there's very little in butter. On the other hand, margarine has an awful lot. If you look at cheese, and if you look at cereal, and if you look at baby formula, it has about 100 units in a serving. Well, that's important. But there are some things that you could do that would reduce the amount of vitamin D that's going to get into the system. So let's say you're fat or obese, as we might say, and you want to go on a diet and you want some kind of assistance. So what kind of assistance? Well, I want some pills. Obviously, I want pills because that's what we do in the United States. We take pills. So you take some Xenical or you take some Ally, and what's going to happen? That's going to interfere with the fat absorption. If you interfere with fat absorption, you're not going to get as much vitamin D. The vitamin D is going out the same way it came in. Or one of the drugs we used to use to treat high cholesterol now is coming back for a variety of substances, variety of reasons, variety of medical problems, and we call it Questran. And Questran can interfere with your ability to absorb vitamin D. And the same thing with some of the anti-epileptic medicines. We used to use a lot of phenobarbital, less so now, but that certainly interferes. Dilantin, phenytoin, still very popular. That can interfere. And then we know that cortisone, if you have arthritis, if you have lupus, if you have a variety of other disorders, and you're taking cortisone, the internal kind of cortisone, not the kind of cortisone that you rub on your skin. But if you do that, if you're taking the cortisone, that's going to interfere with vitamin D. So overall, what are the factors that interact with vitamin D? Well, one of them is you're not going to make it in the skin. You're not going to make it in the skin because you're using sunscreen or your skin is pigmented. And interestingly, the darker you get, if you happen to be Caucasian and you sit outside, and the darker your skin gets throughout the course of the summer, the less vitamin D you're going to metabolize. And we know that, as we mentioned before, the older you are, the season has a lot to do with it. So if you go out, even if you go out between 10 a.m. and 3 p.m., when theoretically the level of UVB is its greatest, and as a matter of fact, any other time it just isn't there at all. Well, if you go out between 10 a.m. and 3 p.m., sometime in April, or May, or June, or July, or even a little bit in September, chances are you'll get some vitamin D if you don't happen to live in an area where it's highly polluted, and if you expose your skin. Has to do, of course, with the time of day. Then we also know that you have to be able to get the vitamin D through the intestines. So one of the situations, as we mentioned before, is it's fat-soluble vitamin. But what happens if you malabsorb fat for some reason? What happens if you have cystic fibrosis? Well, fortunately, that's a relatively unusual disease, but celiac disease is much more common. Crohn's disease, regional enteritis, or let's say you've had bypass surgery to the intestine, not bypass surgery to the heart, bypass surgery to the intestine because you want to lose the weight, or as we said, you're obese, or you're taking some of those anticonvulsants, and now we know that some of the AIDS medicines and the anti-rejection medicine, if you've had a kidney transplant, if you've had a heart transplant, if you've had lung transplant, any of those anti-rejection medicines going to significantly impact on your ability to absorb the vitamin D. And we know that you have a good chance of being vitamin D deficient according to the experts if you're breastfeeding, or since it has to go through the liver to become activated, if you have liver disease, if you have cirrhosis, if you have hepatitis, if you've been drinking too much, well, then we know that that's going to impact on the ability of your body to manufacture the vitamin D. And we know if you happen to have certain kind of kidney diseases. Well, one kind of kidney disease is you just pass a lot of material through the kidneys. You have what we call nephrotic syndrome. Well, that's one of those conditions that can lower your level of vitamin D because your kidneys are pushing it out. Or you could have kidney disease, kidney failure. And we know that kidney failure is relatively common. People talk about stages 3 or 4 kidney failure, and those are tend to be mild to moderate to severe. Well, remember that the vitamin D has to be activated. That's the final stage for activation in the body. And if the kidneys aren't working right, then you have a problem. And then there are certain kind of less common conditions. So, for instance, certain kind of tumors can lead to osteomalacia, and certain kind of infectious conditions where we have what are known as granulomas that can come in the form of tuberculosis. That's a very common one. And we know that there's a condition that sort of mimics TB, and it's called sarcoidosis. We don't really know whether it's infectious or not. And then there are certain kind of cancers where you can get granulomas. We call these lymphomas. And then you can have an elevated level of thyroid hormone. You can be hyperthyroid. And if you're hyperthyroid, chances are you're going to metabolize some of the 25-hydroxyvitamin D. That's the liver-activated form of the vitamin D. And then you have a smaller level. Now, given all of that, we know that a lot of people are said to be vitamin D deficient. You can see how you can get to be vitamin D deficient by the current guidelines, but the overwhelming majority of people who are vitamin D deficient don't have anything wrong with themselves. And as a matter of fact, we know that in the entire world, it would appear that the overwhelming majority of people are vitamin D deficient, and especially here in the industrialized world. On the other hand, we know that those kind of diseases that are associated with real deficiencies of vitamin D, the kind of diseases that we call rickets and osteomalacia, are basically unheard of now. I think in Canada, over a period of time, they only were able to diagnose about 100 cases of rickets. So we're not talking about major disorders. On the other hand, some people would say, well, maybe osteoporosis has something to do with vitamin D metabolism, and it might have something to do to some limited extent. However, as we'll talk about later, you can't get rid of osteoporosis simply by taking vitamin D. So what do we know about vitamin D? The vitamin D that you consume is inactive. The vitamin D that you consume is totally inactive and has to be activated by the body. Okay, that's very important to realize. Now, vitamin D comes in basically 2 forms, at least as far as dietary vitamin D is concerned. We are talking about supplements that contain either ergocalciferol, an ergocalciferol, is vitamin D2. And vitamin D2 is synthesized for use in the supplements by ultraviolet irradiation of yeast. And that's how they get most of the supplements. Now, you can also get it by another chemical called cholecalciferol. That's vitamin D3. So we have vitamin D2, the ergocalciferol, and we have vitamin D3, the cholecalciferol. Now, vitamin D3 is made from ultraviolet irradiation of sheep wool, or it could be made from ultraviolet irradiation of that chemical in the skin that we talked about, the 7-dehydrocholesterol. Now, vitamin D can come from a natural form. Go out and sit in the sun, and if you sit in the sun at the appropriate times that we talked about, then you get some vitamin D. Or vitamin D can come from your diet if you have some tuna, salmon, the fatty fish. Or maybe some egg yolk, or maybe some liver, or maybe the irradiated shiitake mushrooms. They, for some reason, have a lot of vitamin D. So that's another way to get vitamin D, through your diet. Or you could get it through supplements, and if you get it through supplements, you can get it through Fortified Foods. They're sort of supplements, so you can drink milk that has added vitamin D. Or you could get it through traditional supplements by popping a pill. Now, is there a difference between this so-called vitamin D2 and vitamin D3? Yeah, if you happen to be non-human. But as far as human metabolism is concerned, it doesn't seem to make much difference. There's a little difference on the side chain of these, but there's no functional difference if we're talking about how it's metabolized in the system. It's said that the vitamin D2, at least in animals, may be less toxic than the vitamin D3, but that has nothing to do with humans. And it's said that the absorption of the vitamin D3 is supposedly better than the level that you can get from the D2, and it's said that if you're going to consume the vitamin D2, and you can find that out by looking at the bottle of supplements, and it'll say either vitamin D2 or vitamin D3, and if you're taking the D2, it has been said, that you may well need 2 or 3 times as much of it. We don't think that that's true. And as a matter of fact, we think that basically there is bioequivalence. It doesn't make any difference which form you happen to take. If you take either D2 or D3, you will get your vitamin and you will get a sufficient amount. Now remember, vitamin D is a fat-soluble vitamin. So it's going to be absorbed from the intestine in the presence of fat. How do we absorb fat from the intestine? We absorb fat because we have some bile from the gallbladder that's manufactured from the liver, and the pancreas also makes an enzyme, pancreatic lipase, that helps absorb the fat. When the fat is absorbed, then we're going to get the vitamin D. If we don't have adequate amount of bile, if we don't have adequate amount of the pancreatic lipase, chances are we're not going to be able to get that vitamin D into the skin. Now, we know that D3 is going to be hooked up, when we consume it, it's going to be hooked up with some fat, with the cholesterol, with the triglycerides, with a variety of other substances, and it's going to circulate in the plasma as chylomicrons. It's first going to go to the lymphatics, then it's going to go into the bloodstream. We know that the level of vitamin D, or vitamin D itself, is what we call a prohormone. Okay? If we look at what the metabolism is in the skin, you're going to find that the sun, those particular rays that we talked about, getting in sufficiently, getting in adequate amounts, going to hit the skin, and when it hits the skin, then we're going to manufacture some first. We're going to take that 7-dehydrocholesterol and make a substance known as pre-vitamin D3. We find that the 7-dehydrocholesterol is principally located in the surface of the skin, in what we call the epidermis. In the basal layer of the epidermis. You know about those skin cancers, the basal cell carcinomas, that's where they come from, the basal layer. And we know about the squamous cell carcinomas. Squamous cell carcinomas come from the stratum spinosum, the second level of the skin. And we know that those are the areas where you have the greatest amount of the 7-dehydrocholesterol, So the viable epidermis can't wash it off. And we know that that is going to be altered, that 7-DHC is going to be altered into a form that's going to include the pre-vitamin D3. Now, it's also going to be consumed, or also going to be manufactured, some other kind of chemicals. Tachysterol and lamisterol are going to be made. They're going to get broken down. And as a matter of fact, you can't get too much vitamin D through sitting in the sun, because the sun also is going to break down the vitamin D3. So, sun is very important. Now, when we get this pre-vitamin D3, so it goes the 7-dehydrocholesterol, that's changed with the sun, with the ultraviolet irradiation, with those enzymes we talked about, going to be changed into the pre-vitamin D3, and the heat and the sun are going to also change the pre-vitamin D3 into the vitamin D3. And if you get too much of the pre-vitamin D3 or the vitamin D3, that's going to be degraded further into suprasterol 1 and 2, and another form of a chemical that's going to protect you. So you can't get too much vitamin D from being in the sun. You can get skin cancer, but you can't get too much of the vitamin D3. And that vitamin D3 is going to leave the skin. It's going to get into the capillaries in the dermis, the level of skin underneath the surface level. We call that the epidermis. Then comes the dermis. Sits above the fat. It's going to get in those capillaries, and it's going to combine with the vitamin D binding protein that we talked about. And it's going to get into the fat cells. It's going to get into the fat. It's going to accumulate some fat. And then it's going to get into the lymphatics, and it's going to circulate around the system. Now, as a matter of fact, we know that the binding protein that we talked about, the vitamin D binding protein, also going to hold not only the vitamin D3, but it's going to hold the vitamin D that's manufactured in the liver. And as a matter of fact, the vitamin D binding protein is probably most avidly collecting that liver form of the vitamin D, and it also, to some extent, carries around the vitamin D that's manufactured in the kidney. Now, it's important to realize that as we get the circulation of the material, as we get the circulation into the bloodstream, when we get to those organs where there's a lot of lipoprotein lipase, is just an enzyme that's going to break down some fat. Well, in the chylomicrons that are floating around, the place that we get the vitamin D, because it's bound to the vitamin D binding protein and also packaged with some cholesterol and also packaged with some triglycerides and other kind of material, well, we know that it can get broken down in the fat cells, because the fat cells have the lipoprotein lipase, also in some of the muscle cells, the smooth muscle cells. So there's going to be rapid clearance from the bloodstream in some of these organs, and then there's going to be some floating around. And we also know that, especially in the diet, if you're going to get the diet vitamin D, you're going to consume it. Well, we know that some can be packaged instead of with the fat, because remember, it's fat-soluble vitamin, but a little tiny bit can be also stored and combined with certain amino acids and carbohydrates, and from the intestine goes directly to the liver. So what we're going to do is we're going to come back for part 3 and tell you about a little bit more of the metabolism and why vitamin D might have some effects in areas other than just simply the bones. And by the way, what is rickets? What is osteomalacia? And how do they fit into the whole story about vitamin D deficiencies, when these are diseases that you may well have heard of, but almost assuredly you've never seen? I'm Dr. Ken Landau. Thanks for watching.